Hello, this is the Unit 4, Module 14, Chapter 28B presentation. Kaposi's sarcoma in AIDS patients is a malignancy of vascular endothelial cells. The lesions are dark purple, flat or nodular, and often appear at multiple sites in the skin, oral cavity, and the foot soles. Kaposi's sarcoma is the most common HIV-associated cancer. In San Francisco, 15 to 20% of HIV-infected homosexual men develop this tumor during the progression of their disease. Kaposi's sarcoma is uncommon in women and children for reasons that are not clear. Human herpes virus 8, or HHV8, is associated with Kaposi's sarcoma in patients with AIDS. HIV induces cytokines and growth factors that stimulate tumor cell proliferation, along with the HHV8 infection. A protein encoded by HHV8, called nuclear antigen, inactivates the RB or retinoblastoma tumor suppressor protein, which causes the HHV-infected cells to grow in an uncontrolled manner. Lymphomas occur with an increased frequency in patients with congenital or acquired T-cell immunodeficiencies. AIDS is no exception. At least 6% of all patients with AIDS develop lymphoma at some time during the course of their illness. The main categories of lymphoma seen in patients with HIV infection are Burkitt lymphoma and cerebral lymphoma. Approximately 90% of these lymphomas are B-cell in phenotype, and more than half of them contain Epstein-Barr viral DNA. Anal dysplasia, or abnormal growths, and squamous cell carcinoma are also more commonly found in HIV-infected homosexual men. These tumors appear to be associated with anal or rectal infection with human papillomavirus. In HIV-infected women, the incidence of HPV-related cervical dysplasia is as high as 40%, and dysplasia in these women can progress rapidly to become an invasive cervical carcinoma. Pneumocystis is an opportunistic fungal pulmonary pathogen that is an important cause of pneumonia in the immunocompromised host. This colonization elicits an inflammatory response and is associated with a severe decline in lung function. Patients with pneumocystis develop fever and a non-productive cough. Pneumocystis jirovecii is the chief agent of opportunistic fungal pulmonary pathology in AIDS patients. HIV-infected patients are usually ill for several weeks and may have relatively subtle manifestations. The causative agent, Pneumocystis jirovecii, is a tiny yeast-like fungus that was normally classified under the name Pneumocystis carinii. The cell wall of PCP is quite different from many fungi, and it is very, very medicatively resistant. It can also not be cultured reliably in the laboratory. The spores of Pneumocystis jirovecii are easily inhaled into the lungs, where they attach directly to the alveolar walls. Because it is pneumonia, the alveoli will fill with fluid, mononuclear cells, and with masses of growing Pneumocystis jirovecii. Pneumocystis has a worldwide distribution. and most healthy children have been exposed to this fungal organism by the age of 3 or 4 via airborne transmission. Person-to-person transmission has been suggested by hospital outbreaks of pneumocystis pneumonia and by molecular epidemiologic analysis of isolates from such infective outbursts. The data suggest that the cyst of the fungus is the transmissible form. Trimethoprim sulfamethoxazole, or TMP-SMX, acts by inhibiting folic acid synthesis, and it's considered the drug of choice for all forms of PCP. Prophylaxis with this drug pairing is indicated for HIV-infected patients that have CD4 T cell counts of below 200 per microliter. Toxoplasmosis gondii is a widespread intracellular protozoan parasite with a definitive host stage in cats. Immunocompetent persons are usually completely asymptomatic, but immunocompromised persons, especially HIV-positive persons with less than 100 CD4 T cells per microliter, are subjected to reactivation of latent disease with considerable morbidity and mortality. Patients with central nervous system toxoplasmosis most often present with symptoms that are consistent with intracranial mass lesions, and that includes a headache, a focal neurological deficit, nausea, and seizures. They can also exhibit encephalitis with a fever, confusion, and an altered mental status. Toxoplasma gondii is an intracellular coccidian parasite that infects both birds and mammals. Patients with pulmonary toxoplasmosis infections typically have a fever and a non-productive cough, as well as a shortness of breath. The ingestion of oocysts from cat litter or soil, ingestion of bradyzoites from undercooked meat, especially pork, or transplacental migration of tachyzoite forms is thought to spread the disease. In the immunocompromised host or fetal host, the immune factors necessary to control the spread of tachyzoite infection are lacking. This altered immune state allows the persistence of tachyzoites, and it gives rise to progressive destruction that will eventually result in organ failure, necrotizing encephalitis, pneumonia, and myocarditis. The cat is the definitive host in which the sexual phase of the life cycle of toxoplasma is completed. Oocyst forms that are shed in cat feces can infect an enormous range of animals, including birds, rodents, grazing domestic animals, and humans. The bradyzoite form is found in the muscle of food animals that may infect humans who eat insufficiently cooked meat products, particularly lamb and pork. The most common treatment regimen in use is pyrimethamine and sulfadiazine for 6 weeks or until neurological findings have resolved themselves. HIV patients who are seropositive for Toxoplasma gondii should receive prophylaxis or chronic suppressive therapy. This is most commonly achieved using trimethoprim and sulfamethoxazole. Patients with HIV should be counseled to avoid eating undercooked meats and to use gloves when handling soiled cat litter. Cytomegalovirus causes a wide spectrum of disorders in older children and adults, ranging from asymptomatic infections to a mononucleosis syndrome in healthy individuals to disseminated disease in immunocompromised patients, in addition to inducing severe birth defects. Pneumonia and hepatitis in immunocompromised patients, retinitis, and enteritis, especially in AIDS patients, result from cytomegalovirus infection. There is also involvement in the gastrointestinal tract. Cytomegalovirus infection produces a prolonged fever, malaise, anorexia, night sweats, and myalgias. Cytomegalovirus retinitis is an important cause of blindness in immunocompromised patients, particularly patients with advanced AIDS. Fatal cytomegaloviral infections are associated with persistent viremia and the involvement of multiple organ systems. CMV is an enveloped virus with an icosahedral nucleocapsid and a linear double-stranded DNA genome. Viral replication is associated with the production of large intranuclear inclusions and smaller cytoplasmic inclusions. The initial infection with CMV usually occurs in the oropharynx. In fetal infections, CMV can spread to many organisms, for example, the central nervous system and the kidneys. In adults, lymphocytes are frequently involved. A latent state can occur in monocytes. Disseminated infection in AIDS patients can result from either a primary infection or a reactivation of a latent infection. Cytomegalovirus has worldwide distribution. Of the newborns that are born in the United States every year, approximately 1% are infected with cytomegalovirus. The percentages are much higher in many less developed countries. Communal living and poor personal hygiene facilitate the early spread of cytomegalovirus. CMV may be present in breast milk, saliva, feces, and urine. The transmission has been observed among young children in daycare centers and has been traced from an infected toddler to a pregnant mother to her developing fetus. CMV is not readily spread by casual contact, but rather requires repeated or prolonged intimate exposure for transmission. In late adolescence and young adulthood, CMV is often sexually transmitted. Ganciclovir is used to treat pneumonia and retinitis. Acyclovir is ineffective in treating cytomegalovirus. There is no vaccine, but ganciclovir can repress retinitis. Tuberculosis, or TB, is caused by Mycobacterium tuberculosis. TB is an important issue for people living with HIV/AIDS in the United States because, number one, it's estimated that about over 4% of Americans, that's close to 13 million individuals, are already infected with Mycobacterium tuberculosis. The second reason is because as of 2013, the CDC estimates that 6% of all TB cases and 10% of TB cases among people aged 25 to 44 occurred among people who were HIV positive. Mycobacterium avium complex, or MAC, includes ubiquitous atypical bacteria that are found in the environment. MAC causes fevers, diarrhea, malabsorption, and anorexia, and it can disseminate to the bone marrow. Mycobacterium avium can infect patients with HIV and low CD4 T cell counts that are below 100 per microliter. The mode of infection for Mycobacterium avium is usually inhalation or ingestion. MAC causes disseminated disease in up to 40% of patients with HIV in the US, and an infection with MAC produces fevers, sweats, weight loss, and anemia. Disseminated MAC characteristically affects patients with advanced HIV disease and peripheral CD4 T lymphocyte counts less than 200 cells per microliter. Mycobacterium and Mycobacterium intracellular, they are also part of the MAC complex, are saprotrophic organisms that are present in soil and water. Their entry into the host is usually via the GI tract, but it can also be through the lungs. The effective treatment and prevention of MAC has the potential to contribute substantially to improving the quality of life and the duration of survival for HIV-infected persons. Before prophylaxis is administered, the patients have to be assessed to ensure that they do not have active disease due to MAC, due to Mycobacterium tuberculosis, or that they have any other mycobacterial species. This assessment might include a chest X-ray and a tuberculin skin test. This table summarizes HIV infection and its associated malignant tumors and opportunistic diseases. Use the learning objectives for Chapter 28 to guide your study of the information from both this presentation and your textbook. Be sure to define all the vocabulary terms. Take the Module 14 vocabulary quiz. When you are ready, take the Chapter 28 test. This concludes the Unit 4, Module 14, Chapter 28 presentation.